So, may I have your attention, the esteemed faculties and delegates? I would like to take a few moments of your time to introduce myself and the distinguished faculty members of this session. A very good morning and a warm welcome to all the dignitaries present over here today. I am Rituparna from Clarnet, serving as the allocated session assistant to ensure a seamless experience. Clarnet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Clarnet serves as a digital partner for this online event jointly hosted by the Indian Association of Cardiovascular Thoracic Surgeons, Indian College of Anaesthesiologists, Forum of Cardiac Anesthesia, FCA IACTA Bangalore chapter, Global Intensive Care Symposium, International Society of Cardiac Ultrasound, and Global Heart Care Foundation, USA. The focus of today's session is infective endocarditis. And to start with today's Sunday TE session, I would like to present a short welcome video before you.
Good morning, everyone. Can you listen to me?
Yes, sir,
Yes,
you're
sir,
audible.
loud and clear.
Thank you. Thank you so much. I welcome you to the Sunday breakfast session, which deals with echocardiography, both transesophageal and critical care echocardiography. This is being conducted under the auspices of Indian College of Anaesthesiologists, Indian Association of Cardiothoracic Surgeons, Global Heart Care Foundation, Global Intensive Care Symposium, and the International Society for Cardiovascular Ultrasound. So we are really lucky today. We have two eminent faculty with us today, Dr. Divya Gopal and Dr. Parimala Prasanna Sinha, both of them from Jayadeva Institute of Cardiology, which is this institute is doing a laudable work in terms of valve repairs and treatment of the valvular heart disease in general. So it's my great pleasure to invite Dr. Divya Gopal and Dr. Parimala Prasanna Sinha. Before I request Dr. Divya Gopal to take over, I would like to request all the participants to post the comments and question in the chat box. If you want to unmute yourself at the end of the talk, you have the liberty to do that, but preferably you post your questions on the chat box. We'll address all of these questions as far as the time permits. And with that, I would like to thank you once again for joining, and I request Dr. Divya Gopal to introduce Dr. Parimala, and then Dr. Parimala to take over and do the presentation. Thank you so much.
Thank you, sir. Thank you. Good morning, sir. And welcome you all to the Sunday breakfast session of tea and critical care echocardiography. It's my pleasure and privilege to introduce Professor Dr. Parimala ma'am. She is an esteemed, distinguished, and notable senior from Sri Jayadeva Institute of Cardiovascular Sciences, Bangalore. So I request Professor Parimala ma'am to start her presentation. Over
Thank
to
you,
you,
Divya.
ma'am.
Yeah, thank you very much, Divya. Good morning to all. Are you able to see my screen?
No,
No,
ma'am.
ma'am.
Not it. Not
Ma'am,
it.
not yet.
Now, is it seen?
Not yet, ma'am.
Ma'am, if you are shared, please unshare and share once again, ma'am, please.
Okay. It is showing share. Shall I stop say share now?
No, ma'am. Now you just share once again, ma'am.
Is it seen? Are you able to see?
Not yet,
Yet, ma'am.
ma'am.
Just go to the main window. When you went there, just open the PPT and just share, ma'am.
Entire screen.
Yes, ma'am. Just select the PPT.
Now,
Yes, ma'am. It is coming now.
Yes, ma'am.
Perfect.
thank you very much. Okay, we'll discuss about echocardiographic features in infective endocarditis. I have no disclosures. Back in 1885, William Osler said, few diseases present greater difficulties in the way of diagnosis than malignant endocarditis. Even today, occasionally we face this problem, but fortunately, echocardiography and other investigations are uh, better in diagnosing infective endocarditis. But we have to remember that under-diagnosing or over-diagnosing the disease becomes costly for the patient. So we have modified Duke's criteria, and two of the major criteria are from echocardiography. Positive echo findings of oscillating mass, paravalvular abscess, or dehiscence of a prosthetic valve, and another is any new valvular regurgitation. And general considerations are patients are prone to develop infective endocarditis if they have valvular heart disease, especially mitral valve prolapse or prosthetic valves in situ, mechanical as well as bioprosthetic, and if there was a history of infective endocarditis or drug abuse. So infective endocarditis is a dynamic process, and valvulitis may be present before a discrete vegetation is visible using the echocardiography. So this was a case of 18-year-old boy with history of fever and acute right lower limb pain. After 1 month of Ozaki procedure, blood cultures grew pseudomonas, but both transthoracic and transesophageal echocardiography could not detect any valve vegetations. So the question is when we should repeat echocardiography in such cases, or it should be whether transthoracic or transesophageal or any other advanced imaging mode is required. So recently in 2023, we have renewed European Society of Echocardiography guidelines. Here, they say echo should be repeated 5 to 7 days after an initial normal or inconclusive echocardiography if the suspicion of infection remains high, and in patients diagnosed with infective endocarditis at high risk of complication like aggressive microorganisms or in prosthetic valves. So these are from European guidelines. TE is recommended in all suspected infective endocarditis, even in cases with positive transthoracic echo, except in isolated right-sided native valve infective endocarditis with good quality transthoracic examination and unequivocal echo findings. And intraoperative echocardiography is class 1 recommendation in infective endocarditis surgery. So what we see in echo, we will discuss about basic principles and some guidelines. What are all the echo features? Like limitations are there for echo, like we cannot differentiate active from a healed vegetation or a non-bacterial infective endocarditis, or there are limitations in visualizing through prosthetic valve. And then what is the clinical utility of echo in suspected endocarditis? So we are looking for vegetations, their characteristics and size, number, perivalvular complications like abscess, pseudoaneurysm, new dehiscence or intracardiac fistula or leaflet perforation. Additional features are valvular dysfunction assessment, underlying valvular pathology in these patients, impact of valve dysfunction on LV size and function, pericardial effusion or paravalvular abscess detection. Some terminologies are used. Vegetation is an infected mass attached to an endocardial structure or on implanted intracardiac material. Echo will show an oscillating or non-oscillating intracardiac mass on valve or other endocardial structures or on implanted material. Abscess is perivalvular cavity with the necrosis and purulent material not communicating with the cardiac lumen. It is echocardiographically seen as thickened, non-homogeneous perivalvular area with echodense or echolucent appearance. Pseudoaneurysm is perivalvular cavity communicating with cardiovascular lumen. Pulsatile perivalvular echo-free spaces is seen in echo with color Doppler flow. Perforation is interruption of endocardial tissue continuity. Interruption of echo endocardial tissue is seen on echo with color Doppler. Fistula is communication between two neighboring cavities through a perforation. And color Doppler shows communication between two neighboring cavities through a perforation. Valve aneurysm, you can see here, saccular outpoaching of the valvular tissue is seen on echo. Dehiscence of a prosthetic valve is on echo seen as paravalvular regurgitation identified by echo with or without rocking motion of the prosthesis. So these features we are trying to detect in the echo. Vegetations are the hallmark of infective endocarditis. This is infection of the endothelial lining, and it may be present on the valve or devices, or even patients with PD or VSD may develop. You can see here on the mitral valve posterior leaflet, there is a mobile structure attached which is going through the valve, and these are at high risk for embolization. This is showing vegetation on the bioprosthetic valve. You can see the vegetation mass moving both in 2D and 3D. So when the vegetation is small or there is doubt, we have to differentiate whether it is vegetation or any other structure. So features are echogenicity is similar to myocardial tissue in infective endocarditis. Location is on atrial side in the mitral valve and ventricular side in the aortic valve. It may be fixed or oscillating independent of valve motion, and shape may be lobulated, amorphous, stringy, or hand-like strands, narrow attachment, anything may be seen. It is unlikely to be a vegetation if there is reflectance of pericardium or calcium and it is seen downstream of the valve. So the other differential diagnoses are Liebman-Sachs endocarditis, torn chordae or elongated chordae, Lambel's excrescence or nodules of Arantius, fibroelastoma, myxoma, free suture end, LV false tendon, non-bacterial thrombotic endocarditis, and beam width artifact. So here you see Lambel's excrescence. And some artifacts we have to rule out. So these strong reflecting surfaces can give rise to artifacts, and we have confusion whether it is vegetation. There are other characteristics of vegetations. Streptococci and fungi cause more globular, whereas enterococci and other gram-negative organisms cause long filamentous. Its general feature, it may be mixed. Size increases with duration of infection. We can score the vegetation based on the characteristics. If it is fixed, it is grade 1. Calcified also grade 1. Grade 2 is fixed base but free edge. Grade 3 is pedunculated. Grade 4 is prolapsing through the valve. And other features are, if it is on anterior mitral leaflet, a higher risk for stroke. In aortic valve, the endocarditis is difficult to treat and mortality is higher with aortic valve vegetation and embolization. If vegetation size reduces with antibiotics, prognosis is better. Embolism can occur long after treatment. So next we'll discuss about mechanisms of valvular regurgitation. First, it is perforation of leaflet from the abscess. So you can see here the aneurysm, valve aneurysm, and in this view, you can see there is vegetation and a perforation in the anterior mitral leaflet causing a regurgitation at posterior commissure. Intraoperatively, you can see the cannula in the anterior mitral leaflet. Such extensive diseased valves may not be repairable, so they may require replacement. This is showing both aortic and mitral leaflet perforation and causing severe AR and mitral regurgitation. So the other is impairment of leaflet coaptation by prolapsing vegetation. When this leaflet prolapses through the valve, the coaptation is inadequate and severe regurgitation is seen. It can be seen in different views. This is apical four-chamber view, then parasternal short and long axis views. Then a leaflet prolapse or flail due to ruptured chordae may also lead to regurgitation. Here you can see two of the chordae from the anterior mitral leaflet are prolapsing. There may be associated features of valvular regurgitation like enlargement of the ventricle as well as left atrium. Initially, ejection fraction is good, later it may reduce. Now, what are the indications for surgery? In native valves and acute infective endocarditis with congestive heart failure and acute AR or MR with elevated LVEDP, or infective endocarditis by fungal or resistant organism and with complications, heart block, abscess, or obstructive lesions, it is class 1. And class 2A is persistent vegetation or recurrent emboli despite antibiotic therapy. Class 2B is mobile vegetation more than 10 mm. In prosthetic valves, class 1 indication is heart failure, valve dehiscence, valve regurgitation or obstruction, abscess. Class 2 is recurrent infection. Class 3, routine surgery is not indicated in first infection. So more detailed indications are persistent vegetation following systemic embolization, AML vegetation, especially larger than 10 mm, one or more embolic events during first 14 days of antimicrobial therapy, growing vegetation despite appropriate antimicrobial therapy, acute mitral or aortic regurgitation with signs of heart failure, and heart failure that does not respond to medical therapy, paravalvular extension, dehiscence, rupture, fistula, new heart block, abscess. All these are indications. So perioperatively, we look for the extent of infective endocarditis, location and size of abscess, and involvement of other chambers, ventricular function. So this is pre-bypass echocardiography transesophageal showing dilated chambers and vegetation which is highly mobile, and in fact it has caused perforation in the mitral leaflet. You can see the perforation and regurgitation. This patient also had pericardial effusion, and a mobile mass is seen through the mitral orifice as well as posterior commissure site. There is a echoluscent area with regurgitation which is freely communicating. So it could abscess or maybe leading to pseudoaneurysm in such patients. Sometimes vegetations can cause mitral stenosis also, not allowing the valve leaflets to open. There may be underlying valvular disease in these patients. So here you can see a apical four-chamber view with the vegetation which is moving through the valve but not allowing the valve to open freely. A very much reduced mitral orifice with a gradient of 19/8. Now, after surgery, if patients, when especially there is abscess or commissural involvement, there may be a difficulty to close the defect, and if patient develops moderate or severe MR, the treatment will be as with any other case. But sometimes we see small paravalvular regurgitations. This patient had undergone bioprosthetic valve implantation, and there was a paravalvular leak of 2 millimeters or so. So such patients we observe, but if these patients require further treatment, we'll have to follow up. Now, embolic risk is high if vegetation is more than 15 mm, neck to thickness ratio is more than 0.69, maximal angle of displacement of vegetation in the cardiac cycle is more than 60 degree, and during antibiotic treatment, embolic risk depends only on vegetation mobility and dimension. You can see here the neck and pre pedunculated mass. It has to be measured in two orthogonal planes. So these are the risk factors for occurrence of embolic event after antibiotic therapy started. Depends on the maximum length of the vegetation, more than 15, or maximum thickness of vegetation more than 5 millimeters, neck to thickness ratio less than 0.5, maximal angle of displacement of vegetation more than 65, etiology staphylococcus, then site of vegetation. Right heart is more at risk for embolization. Predictors of poor outcome are periannular complications like severe left-sided valvular regurgitation, left ventricular dysfunction, pulmonary hypertension, large vegetation, severe prosthetic valve dysfunction, premature mitral valve closure, and other signs of elevated diastolic pressure. Now we'll discuss about prosthetic valve endocarditis. It is 1% during first year and reduces later. It may be more in the first year. Suspicion, if there is suspicion of infective endocarditis, it is an indication for transesophageal examination. TE helps in detecting vegetation, abscess, paravalvular leaks, dehiscence, holes in the bioprosthetic leaflets. High negative predictive value if repeat TE is negative, and urgent surgery essential as poor response to medical therapy in prosthetic valves. So intractable heart failure, valve dehiscence and dysfunction, heart block, annular abscess, and gram-negative bacteria, highly antibiotic resistant organisms, persistent bacteremia despite 7 to 10 days of therapy in prosthetic valve endocarditis will be indications for surgery. Here you see that the prosthetic valve is dehiscence and there is rocking motion of the valve as well as severe mitral regurgitation. Here also you can see the paravalvular leak. So paravalvular leaks are due to suture dehiscence or infective endocarditis. Jet is seen outside the sewing ring. Rocking motion of the processes may be seen, and these are pathological. So when we did 3D TE, you can see there are two defects in this patient, and instead of surgery, a device closure was planned. The first device was positioned in the paravalvular perforation, and while trying to position another device, one of the devices embolized, and we could see it in transthoracic echo. The device was subvalvular, entangled in the chordae. So these are difficult cases to manage overall. Prosthetic regurgitation features. In severe mitral regurgitation, we see paravalvular leak. Dehiscence is defined when there is more than 40% of the circumference is freely mobile and there is severe mitral regurgitation. Forward flow is increased with normal pressure half time in these patients. Jet vena contracta is more than 7 mm and pisa radius more than 1 centimeter. There is a shoulder seen in the continuous wave Doppler signal due to steep rise in left atrial pressure. So severe prosthetic regurgitation of aortic valve also leads to paravalvular leak or dehiscence. There can be premature mitral valve closure and shortened mitral E wave deceleration time, increased trans-aortic flows, difficult to measure jet vena contracta. These are maybe more than 1 centimeter radius, and pressure half time less than 200 milliseconds. Flow reversal in descending thoracic aorta. It may be underestimated by 2D. You can see the valve showing vegetation on the aortic side. There is minimum, but the LV view, you can see a large vegetation here. So comparison of 3D over 2D for prosthetic valve endocarditis diagnosis. It is superior in detecting vegetations, dehiscence, abscess, and regurgitation. So role of 3D is especially for prosthetic valve endocarditis and complications of infective endocarditis. 3D measurements more than 3 millimeter compared to 2D vegetation size. Shape and attachment of vegetation is better visualized, and more than 20 mm in the mitral valve predict embolic risk. A few points about tricuspid valve vegetation, and especially if there is pacemaker related endocarditis, TE may be required. Indication for surgery is microorganisms difficult to eradicate or persistent fungi, bacteremia for more than 7 days despite adequate antimicrobial therapy, persistent tricuspid vegetation more than 20 mm after recurrent pulmonary emboli with or without concomitant right heart failure, or right heart failure secondary to severe tricuspid regurgitation with poor response to diuretic therapy. So in summary, echo helps to decide potential surgical interventions in acute severe regurgitation, paravalvular abscess. Timing of surgery is decided by LV dysfunction, multiple valve involvement, pH, recurrent embolization, and it helps in predicting short and long-term prognosis. Sequential TE predicts whether antibiotic therapy is effective in reducing the size of vegetation, and risk for factors for mortality are prosthetic endocarditis, systemic embolization, and Staphylococcus aureus infection. Long-term outcome depends on residual valve damage, effects of valve regurgitation on LV function, pH, and risk for embolization. Thank you.
Thank you, Parimala ma'am. That was a very comprehensive and informative talk. So the discussion is open. The talk is now, it is open for the discussion. So any questions from the participants? They all can type it in the chat box.
Okay, there is a question of sharing grading of vegetation. I'll share it later.
Yes, ma'am.
Thank you, Dr. Parimala. That was an excellent presentation. You gave the overall what do you call overall view of the issue of infective endocarditis.
Thank you, sir.
It was well done. With Dr. Parimala in the last 30 minutes has gone into the major aspects of echocardiography in infective endocarditis. What are the indications for TEE in endocarditis? What are the echo features? What are the characteristics of vegetations? What are the consequences of infective endocarditis in terms of vegetation, abscess, pseudoaneurysm, perforation, fistula, aneurysms, valve dehiscence, etc.? What are the characteristics of vegetation? And what is the differential diagnosis? What are the indications for surgery? And importantly, check out the aspects of prosthetic valve endocarditis, one vegetation. What are the mechanisms of MR involved in these patients? And I think that's gist of what was discussed. So we are open for discussion. So will you share the slide which says grading of vegetation? Very important. You
Okay,
have to share the screen once again and go to that slide.
Are you able to see?
No, not it. In the meantime, can you answer how to differentiate between vegetation and cardiac mass?
Yes, sir. 1 second.
I can just give a brief answer to this. You can modify that. Vegetations are usually on the atrial side in case of mitral valve and ventricular side in case of aortic valve. And they are similar to the myocardial tissue in texture. So it resembles the myocardial tissue echocardiographically. And they can be associated with the implanted material or the native valves if they are infected, or they can even be present on the endocardium. And they can be either fixed or mobile. I think that will come in the grading. And when do you do surgery with stable infective endocarditis? Another question. I think this was also mentioned. I would like to repeat it.
Are you able to see my screen?
Not it.
Oh.
Madam, please
Yeah.
You have to
Again,
share
in
the
same.
screen.
Please unshare the screen once again.
I'm unable to open that. Stop sharing. Now is it seen? Hello?
Yeah, we can see.
Yes,
Just
ma'am.
we have to show two things. One is the grading.
Yes.
Second is the surgical indications.
Vegetation graded based on the size as well as the stability of the uh, vegetation. If it is fixed and it is calcific, it is an old vegetation which is at a lesser risk for embolization. So grade 2 is the base is fixed, but the tip is freely moving. Third is pedunculated mass. That is, the mass has a peduncle and then it is freely mobile. Grade 4, it is already prolapsing across the valve. So as the grade increases, the risk of embolization also increases.
Thank you for that. So we have 4 grades: fixed lesion, fixed base, free edge, and pedunculated and prolapsing. 4 types are there. Now go to the surgical indications. The question is, in a stable patient on antibiotics, do you have to operate them? Anyway, first go to surgical indications.
Yes, sir. So 2023 European guidelines are available for, there are some revised guidelines.
I think you skipped this slide, it went past.
I think indication for surgery.
Okay.
So this is in prosthetic valve endocarditis, intractable heart failure, valve dehiscence, heart blocks, annular abscess, and difficult organisms to treat. Then persistent bacteremia despite antibiotic therapy for 7 to 10 days.
Yeah, this one.
Yes. So there is persistent vegetation following systemic embolization, or vegetation which is on anterior mitral leaflet, and if it is more than 10 millimeter, and there is already history of embolic events during first 14 days of antimicrobial therapy. So these may look stable vegetations, but if there is history of embolization, then or if it is growing vegetation, then there is indication for surgery, even if it is a stable vegetation. Then other features of problems with vegetation like valve regurgitation, heart failure, paravalvular extension, and other complications will definitely be indication for surgery.
So if the patient is stable and has none of these issues, but that's a vegetation which is not collapsing or threatening to embolize, is it okay to continue the antibiotics for 6 weeks and then follow up the patient?
Pardon, sir?
If the patient is stable, the question is, what do you do in a patient who is stable and he's on antibiotic and has none of these features mentioned here? There's no systemic embolization. It is smaller than 10 millimeters, and there are no embolic events, and it's not growing. There are no signs of heart failure, no paravalvular extension, no valve dehiscence, no heart block, and there's no abscess. So in these cases, you just continue the antibiotic for 6 weeks based on the blood culture reports and then follow them up. Do you agree
Yes,
with
sir.
that, Dr. Parimala?
Yes, sir. Yes, sir. We had a few patients, but if they have come back after prosthetic valves with endocarditis, and even if there are no vegetation, sometimes early diagnosis is difficult in these patients. Only positive blood culture was seen, and in those patients, MRI showed perivalvular abscess actually.
Oh,
So, if there is persistent bacteremia even after therapy, these patients may need advanced imaging like CT or MRI,
yes.
and then decide about surgery.
What is the incidence of infective endocarditis?
It is like prosthetic valve, they say 1% after
Yeah.
First year. During first year, 1% of patients may develop infective endocarditis. In general population, it is there. I'll just take the reference and
The incidence of infective endocarditis varies whether you are talking about native valve endocarditis or prosthetic valve endocarditis.
in native valve, it is 1.4 to 62%
Yeah,
cases per 1 lakh persons. In 1 lakh, 1 to 6% for a native valve endocarditis.
Next question is, how do you differentiate aortic valve vegetation from thrombus, tumor, Lamble's excrescence by echo?
The sir has already explained. One is it is on the LV side, and there are other features like Lamble's excrescences are very thin strands, and patient doesn't have any other features of
Right,
infective endocarditis.
right,
Then a tumor or mass will have like fibroelastoma will be confusing, but it is also at high risk for embolization. But the features are different. It never grows in size. Not like infective endocarditis vegetation, and it may be more uniform or globulated like structure. Then thrombus may be on either side, maybe on the aortic side also.
Mhm.
Much I remember, sir.
Right. How do you approach merantic endocarditis?
I do not know about this.
It's a non-bacterial thrombotic endocarditis, also called as Liebman-Sachs endocarditis, that causes sterile vegetations and most
Okay.
often affect the aortic and mitral valves. It may be associated with hypercoagulability states, cancer, autoimmune diseases, and HIV. It can be confused with infective endocarditis. They are
Okay.
sterile and non-bacterial. Basically, they are sterile, non-bacterial.
Okay.
What preventive steps to be taken for avoiding systemic embolization? Any role of perioperative nurse?
This question is mainly during surgery, I think.
Right.
So, what I feel is if they have received antibiotic therapy previously and vegetation is more stable or non-pedunculated, or it's not highly mobile or prolapsing, then the risk will be less. But
I
otherwise,
would say that avoid handling of the heart and go on bypass as quickly as possible, cross clamp the aorta, prevent any systemic embolization. Then you open and remove the offending object.
okay, sir.
Nits can be used, but once embolization has happened, it can only say that it has happened, but it's not going to prevent it. So the preventive steps will be minimum handling of the heart and go on bypass as soon as possible and cross clamp the aorta and give cardiac and then remove the vegetation. Is mobile or whatever. The next question is if the
There's
patient
One
whether
is
more one more
yes,
question by Dr. Karthik Jain
yes,
N.
yes,
If
yes,
patient
yes.
is very sick, then how to decide for surgery?
a patient, we have taken these patients in heart failure despite
Yes,
antibiotic therapy to save them, but it is having high operative or post-operative mortality also. But that is the only alternative when they are not responding to medical therapy.
right, right. Do you wash the surgical site with rifampicin or any other antibiotic solution in these cases?
Yes, surgeons usually take care, especially if there is abscess.
Yeah,
They will handle it carefully, and uh, then local antibiotics are utilized there.
yes. And it is very important to debride the valve or endocardium so that there's no residual matter left there. And as far as possible, go for natural uh, prosthetic agents like pericardium or um, homografts or bioprosthetic valves, depending upon the situational requirements when you're dealing with this. Because if you put a prosthetic mechanical valve again, may be prone to endocarditis and the problem will be recurring once again. Do you agree with that?
Yes, sir.
I'm happy that you went to the recent guidelines and you said that TEE is recommended in all suspected endocarditis and intraoperative TEE is class 1 recommendation. Please remember that intraoperative TEE is class 1 recommendation. Marantic was already discussed. It's a non-bacterial endocarditis which forms vegetations. It's seen in hypercoagulable states and patients have carcinoma and HIV. And to repeat or to recollect the vegetations, the infective endocarditis can manifest as vegetations, abscesses, pseudoaneurysms, perforations, fistula, valve aneurysms, or valve dehiscence. And the grading of vegetation was mentioned, grade 1, 2, 3, 4. And indications for surgery were also mentioned. And the echo characteristics were mentioned. And special mention about valvular prosthetic valve endocarditis and vegetations also mentioned. There is one question on residual ASD or BSD may cause infective endocarditis in future. Will it cause?
VSD, PDA, they have mentioned about risk for endocarditis, and after device closure, initial 6 months are still high risk for infective endocarditis, and they need prophylaxis. ASD, I do not know.
Yeah, ASD, isolated ASD carries a low risk, but the high risk conditions are prosthetic valve or a valve repair with a ring, previous history of endocarditis, heart transplant with cardiac valvulopathy, and uncorrected contemporary heart disease, especially, I think Dr. Parmala mentioned about PSD and PDA.
So recent guidelines say even patients on VAD and post-transplant may be candidates for antibiotic prophylaxis for infective endocarditis.
And how about pacing wires and pacemakers? Is there a enhanced risk in them?
If they develop, then they require explantation and reinsertion from a different remote site other than the previous site.
Right.
They are at risk, especially right-sided endocarditis, and they may require endocarditis prophylaxis.
Right. Divya, you want to add anything before we conclude? Anybody else wants to say anything? We have about 9 minutes to go.
Yes, ma'am has presented, given us a very good presentation.
Yeah.
The point that the 3DT is more superior to the 2D features. So we should really start doing 3DT more, and so that more in definitive information is information we get about the pathology.
That's right. Actually, Dr. Parmala mentioned that in 3D it is larger than what we see in 2D. Is that so, Parmala?
Yes, sir. We may not be able to see the full extent of vegetation in 2D, which 3D from LV side also, especially aortic vegetations, we can see clearly.
I think with that, I request Divya to make concluding statement, and then we'll go on to the video of the workshop.
Yes, sir.
Thank you, sir.
Thank you, sir. Thank you, Parimala ma'am, for your talk. All of us got educated, little more education on infective endocarditis with respect to echocardiography. Thank you, Muralidhar sir, for your relentless and continued efforts in educating all of us. We are really blessed and privileged to have this breakfast session, tea sessions every Sunday morning. Thank you, and thank you all the participants to have taken out time and attended this session. Thank you all. Thank you.
Thank you, Dr. Divya, and thank you, Dr. Parmala, for being with us. Now, I think, Ritu, can you play the
Sure, sir. Just allow me a
workshop
minute.
video? After that, we'll conclude. Thank you. Thank you so much. Have a great Sunday. We'll see you again next Sunday. Thank you
Thank
very
you.
much.
Thank you,
Thank
dear
you, sir.
doctors, for sharing such valuable insights. I
Thank
hope
you,
you had a
sir.
seamless experience. And
Yes.
thank you once again for giving us this opportunity to host a session and looking forward to host you again soon. Till then, stay safe and healthy. Goodbye to you all, sir.
Thank you. Thank you,
Thank
Rebecca.
you.
Thank you.
Thank you, sir. So with all your permission, we are signing off for today then.
Thank you.